Ni twa ni ri sharp hi ku ri yini sweswi na swi kota ku tlanga na vana van'wani ene nwa tiphilisi ta me kahle a va swi voni ku ri yini na vabya.
Nna gore ke bona gore bophelo ba ka bo tšhentšhitše ko o kgona go tseba gore dipilisi tše di nwa ke batho ba bantši bjale ka kgona go ba free.
Ena ke happy, ke sa na bothata cause ke amogetše.
Now I am a friend that I never had.
Good morning. Good morning, everyone. Thank you. So I think other people will find us on the way. Ne? Let's start the session. Okay. Welcome to Pillar 2 of the Global Alliance to End AIDS in Children by 2030 strategy. Okay. Okay, so as announced earlier on, we hope everyone has come to the Pillar 2 that talks about pregnant and breastfeeding women living with HIV. Ne? Okay. All right, let's move ahead. Introduce myself. I'm Thabisa Seleche Maqhetseba, and I'm the country representative from PATA for South Africa, but I also lead the HIVE program. I also have my co-facilitator with us, Dr. Puri Gonzalez.
Hello, everybody. My name is Puri Gonzalez. I'm the country representative for PATA in Mozambique, running the Breakthrough Partnership Project. Thank you.
Thank you, Dr. Puri. So you'll see our speakers on the slide, but I'll introduce them more as we move along with the session. Next slide, please. Great, so just a brief introduction into Pillar 2. So we believe, I think all of us here in the room, that a stepped up approach of efforts to prevent mother-to-child transmission could lead to a steady reduction in new HIV infections among children, with the number of children who acquire HIV in 2023. And probably also looking at the challenges that are faced by pregnant and breastfeeding women, I think in all our countries, you could say that the global coverage masks a deep inequality between the country and region populations, and as well as persistent challenges with respect to retention and care for pregnant and breastfeeding women. So for this particular pillar, we want to look at optimizing treatment coverage, and not only for health, but for also the well-being of pregnant and breastfeeding mothers. And this is critical to prevent transmission. Is it too loud? No? I could also feel, yeah. Okay, so, is this better? Is it better? Okay. So, apologies for that. So we believe that optimizing treatment coverage is critical, not only for the health and well-being of pregnant and breastfeeding mothers, but it's critical also to prevent transmission to newborns and infants. So we've got a quote there from the Elizabeth Glaser organization that says every child, every family deserves a future free of HIV. And we have the tools to do all of this. We just need a lot more commitment. Ne? And I think that's why some of us are here to learn some of the great interventions we could take back home countries. Next slide, please. Okay, great. So the key objectives of this Africa Cafe for Pillar 2 is to enhance participants' understanding of the key components of Pillar 2. Secondly, to promote high impact evidence-based strategies on how to close the treatment gap for pregnant and breastfeeding women. To facilitate discussions and share country or health facility experiences, best practices, lessons learned, tools and resources to adopt differentiated approaches to increase PMTCT coverage, also to improve quality of care and to implement an integrated approach to triple elimination. The fourth objective is to motivate and build momentum amongst participants to participate, to mobilize resources, implement and take to scale up those mentioned in implementation models in our respective fields of action. Next slide. So Pillar 2 would look at these key areas of implementation. The first key area would be adoption of these differentiated approaches to increase PMTCT coverage. And there we're talking issues around integration of the PMTCT program within our maternal and child care programs. Also, we're looking at delegation of tasks and decentralization. So what are the key activities we could implement to decentralize some of our service implementation to a lower level? And then also looking at a family-centered approach. This also includes your baby mother pair, your now, which is trending, a father baby pair. And then also secondly, we want to look at improvement of quality of care to improve retention and continuity of care. That talks to promotion of viral load monitoring and management. It also highlights the psychosocial support that's needed by pregnant and breastfeeding women. And then also looking at what are the tools we have in countries that looks at a longitudinal cohort monitoring for PMTCT. And then also the third thing would be addressing the needs of pregnant and breastfeeding adolescents living with HIV. And that talks to us having strong social support in terms of peer-to-peer-led programs, and also looking at multi-sectoral approaches to support the livelihood, mental health, and early childhood development. And I think most of our countries now are part of the Global Alliance to End AIDS forums, and that should be the forum we are looking into for multi-sectoral approaches. And then lastly, it's really looking at integrating the triple elimination we heard about this morning for HIV, syphilis, and hepatitis B, and also looking at the integrated surveillance for all the triple conditions that are under the triple elimination. Next slide, please. So for this particular Africa Cafe, we are going to look at the three presentations. These presentations are coming from Zimbabwe. We've got presentations coming from South Africa, but most importantly, we would have discussions that are coming across all the different countries that are here. And would really love for you to assist us in that participation and discussion, because we understand that these sessions are meant to be a learning platform. So the first presentation will be coming from Dr. Natasha Davis from ANOVA. This presentation will be done online. She was here with us yesterday, but today and tomorrow she cannot be, and she apologizes for that. And then the presentation will mostly focus on DSD models for pregnant and breastfeeding women, in mobile populations in country and outside of country. Just to highlight that we have really brought in this presentation so that we can ignite a discussion around our population that we know moves a lot. So we've got population that moves within country and also from outside of country. Let's just share ideas and strategies on how can we better manage this population. And then the second presentation, we look at implementation of postnatal clubs and EGK code, which is an electronic gatekeeping code for monitoring to improve maternal viral load coverage and suppression. This presentation will be coming from Ms. Frida Mahlangu from VETS RHI in South Africa. The last presentation will be coming from Ms. Peggy Kuchocha from Zandiri in Zimbabwe, and it talks about experiences in implementing the Zandiri Young Mother Mentor and Dad Peer Program. So exciting for us now to look at what can male bring to the table, if I must say that. What can the daddies and the fathers help us in terms of the vertical transmission? Last slide, please. So thank you very much for being here, firstly. And then again, I would love to invite your ideas and strategies as we go through these 3 presentations. So firstly, I'd like to invite my first speaker. Okay. So my first speaker, as mentioned, will be online. Dr. Natasha Davis is an HIV clinician with over 20 years of experience within the South African ART program. She sits on the National DOH ART Vertical Transmission, PrEP, and Third Line ART Guidelines Committees. Her clinical and public health focus is supporting pregnant and breastfeeding women living with or at risk of acquiring HIV, including those with non-suppression and AHD. So we also have Ms. Lindiwe in the room who will be answering some of the questions that will be coming from this presentation. So we can go ahead and do the online presentation. Thank you.
Thanks very much for the introduction and for this opportunity to present. I'm excited to be part of this really important summit. I'm just going to give some background information about the situation around migrants in the African region. So internal and cross-country migration is common. And you can see from the map on the right-hand side of your screen that one particular hotspot is South Africa, where we have a lot of migrants coming into the country year on year. The key drivers are economic challenges, but newly so climate change and also increasing conflict in the region. One of the challenges for people who move around Africa is that up to 15% of them are undocumented, which creates particular vulnerabilities when it comes to accessing health services. And from South Africa's point of view, up to 60% of SADC migrants head this way, and 5% of our total population is made up of migrants, primarily from Zimbabwe, Mozambique, Malawi, Lesotho, and Swaziland, but also further afield from places like Nigeria and Angola. And as an example, in central Johannesburg, which is one of our main sort of attraction areas for migrants, up to 50% of the resident population are actually internal or cross-border migrants. When we break it down to the women migrants, 40% of African migrants are actually women, and in one hospital that they looked up in Pretoria, 1 in 4 of the infants being born there were born to migrant women. So migration definitely does affect women and their babies, and it has an impact on their access to health care. So some of these women are migrating for the usual reasons, but there's also an increased migration to access quality healthcare. And in South Africa, very importantly, our Constitution and National Health Act clearly allows for free healthcare for pregnant and breastfeeding women, whether they're migrant or not, and regardless of documentation status. But unfortunately, the reality of implementation of these policies on the ground is not always so nicely done. So migrant women experience really significant health systems barriers that leave them highly vulnerable. For those women living with HIV, they've got higher rates of viral non-suppression and vertical transmission, and often have advanced HIV that leads to poor pregnancy outcomes, maternal mortality, and there are also issues of high rates of teen pregnancy. And despite all these challenges, we don't have that much attention being given to this particular group when it comes to healthcare service provision. One of our big challenges around migrants and their access to healthcare is healthcare provider attitudes, and there's been a lot of qualitative research on this, that where healthcare providers have been quite comfortable to share the fact that they see migrants as being a burden on the health system, making their work harder because they often come when they're more sick or come late, and then there's not time to resolve their issues. And there's feelings of distrust that they are ungrateful and abusing the free services provided, and that they're cheating the system, attending lots of different clinics and potentially sending medications home or reselling them for profit, of which there hasn't been any evidence, but it's sort of a myth held within the healthcare provider psyche. On the other side of things, there's been qualitative work looking at the experiences of migrant women who are living and accessing services in Johannesburg. And unfortunately, what they experience is this sense of street-level bureaucrats. So you've got the policies at a high level, but what's happening is that on the ground, healthcare providers and admin staff are sort of becoming informal gatekeepers, implementing their own policies, which lead to delayed or denied care, negative attitudes and verbal abuse. And these sorts of negative experiences lead these women to go to multiple facilities because they're trying to find a safe space where they're not required to provide legal identity documents to access care. And then when they do access care, there are issues of language barriers, low literacy, and obviously the psychosocial stressors that come with migration, including financial challenges, poorer, unstable living and working conditions, food insecurity, that then all contribute to poor health outcomes, as well as isolation and mental health issues arising from depression, anxiety, trauma, the need to move and be away from your family, and all the fear that comes with being a migrant leads to a more higher likelihood of late booking and poorer health outcomes. So that's the sort of background information, but just to bring it into relief, I want one Zimbabwean lady who I met a couple of weeks ago. She was diagnosed in South Africa during a previous pregnancy in 2021 and started on TLD. But after she delivered, because she was undocumented, she hadn't been provided with a transfer letter. And she was really scared of going to a local clinic because her sister had had negative experiences when she tried to access care. She decided not to go to a clinic postnatally. Instead, she traveled home to Zim with her baby for a few months, registered at a clinic there, got herself sort of settled, and then moved back to South Africa and became reliant on a family member going back to that Zimbabwean clinic to pick up her treatment every 2 months and send it across the border. But that often meant that it came late, and she had repeated treatment interruptions, including twice during this current pregnancy. It also meant she wasn't going back to her clinic for monitoring, so we had no idea what her viral load had been like. And when she did book, although they noted on her document that when she booked at 7 months pregnant, she was on ART, they didn't do a viral load at booking as is required by the guidelines, and it was only done 6 weeks later. And it was very high, and she was also identified to have advanced disease and anemia. And when I saw her just 10 days before she was due to deliver, it was clear that she hadn't had correct management or monitoring. She wasn't given the prophylaxis she needed for opportunistic infections, and she still had a very high viral load. When she came to the hospital to see me, you can see that on her appointment card, she had this ugly sticker stamp put on, which made her feel quite uncomfortable because she felt like she wasn't meant to be there. And she was booked to see me again last week and unfortunately didn't come back. And I suspect that that was access issues as well. So as much as there are cross-border migrants, there are also internal migrants within South Africa, over 1 million of them every year. And in particular, it's young men and women of reproductive age who are moving around, seeking jobs, looking to be closer to partners and families. And in particular, we see high rates of migration between Limpopo and Mpumalanga and Gauteng and Eastern Cape and Western Cape. So these are sort of hotspots for where we see internal migrants moving around. And one of the big barriers to continuity of care for these highly mobile young people living with HIV is the required transfer letter, which is sort of a standard administrative process that's in place in South Africa. And despite the fact that it's clearly stipulated in our vertical transmission and adult ART guidelines that patients do not need to have a transfer letter, I repeatedly come across patients who are experiencing a treatment interruption or have disengaged from care because they've moved between provinces, and when they've tried to go to a new clinic, they've been told they have to have a transfer letter and must go back to their previous province, but many of them don't have money or time to do that, and then they stop taking their ART. I was asked to also speak about the maternity case record and how this might help us with our internal and cross-border migrants. So in South Africa, we've got an antenatal maternity case record, which is really very comprehensive. And these are just some photos of the pages of it. Unfortunately, I wasn't able to get a completed one to take photos of. So they've just released a new one at the end of 2023, which has a lot more focus on HIV and vertical transmission prevention. So the staff are prompted to look at the HIV status, the CD4 count, the viral load, and to document if the woman is living with HIV. And there's these two new pages that have been added. One is a PMTCT checklist. Unfortunately, it doesn't say VTP, and it's around testing and antenatal care for women living with HIV and what happens to them and their infants at labor and delivery. And then importantly, there's a new discharge letter, which is specifically focused on implementation of the vertical transmission prevention guidelines in terms of checking the mum is on treatment, the feeding has been discussed and set up, there's contraception provided, and there's a full plan of postnatal care for the HIV exposed infant. So it's a really good intervention to have these two new pages in the antenatal record. And the benefits are that it's very comprehensive. The woman holds onto it herself. So if she is mobile, she will have this record that providers at any facility can use. And there are these clear HIV management components that's being accepted across the whole country, across all the different provinces. But I think one of the challenges is going to be that it's a lot of capturing for very busy staff at antenatal clinics where they may be looking after 40, 50, 60 women a day. So to try and expect them to complete these extra pages is going to be quite a challenge. And also it's retained at the delivery unit after birth for maternal outcome audits. So there's no postpartum continuity. Although this new one with the discharge letter has been implemented for a few months at some facilities, I've never seen that discharge letter completed as yet. So I think one of our biggest challenges is maintaining that continuity of care from antenatal to postnatal and that risk of the broken chain in care. And we know, very importantly, that in South Africa, almost 2/3 of all our infections are coming from breastfeeding. So our postpartum care is really important. And the other issue is that nowhere in this document is PrEP flagged or mentioned for women who are testing HIV uninfected, and yet 1 in 3 of our new infant infections come from new maternal seroconversion. So I think that's a significant gap. So one question that I wanted to raise for people to discuss is whether there's any scope for a postpartum maternal case record that would travel with the Road to Health booklet. So how can we do better for internal and cross country migrants. I think a key piece of work that we need to look at is sensitizing healthcare workers and bringing some humanity back into our healthcare system to address xenophobia. I've often been quite shocked with how open nurses are willing to be about their feelings around foreign women who are accessing our services. Really important to clarify the policies around free care and to try and overcome this issue of the street level bureaucrats who are making it difficult for women to access the care that is their human right. I think we should be looking at a postnatal maternal care record that mirrors this antenatal one. It's a good document, but it falls short in that most of our breakdown in care is happening postnatally, and there is no maternal record postnatally. So if we could do something to make sure that as much as the infant has the Road to Health booklet, the mother NATO Club model expansion for a couple of years now, and we've got several hundred groups that are operating across our districts. And what we've seen is that it provides a lot of postnatal care stability with an important support structure for women who are breastfeeding and are maybe at risk of vertical transmission. And across the 2 districts that are implementing, we've only seen 1 PCR positive over the last 2 years. It helps to reduce the woman's isolation, and it also gives an opportunity to identify when a mother-infant pair isn't attending the facility anymore. So although it may not be specifically addressing issues of high mobility in migrant populations, I think it might be an opportunity where we could engage with women who are highly mobile to educate them and equip them in order to plan when they need to move and to give them the transfer information that might help them when they need to change facilities. I had a lady from Malawi a couple of weeks ago who I could not communicate with at all. We were just stuck. And then I remembered that I have a colleague who speaks Chichewa. I picked up the phone to her, put her on speaker, and she translated for us. And it was extraordinary to see the difference in this lady. She suddenly became human and animated and like alive in front of me because she had someone who could help her communicate, and it totally changed my management for her. I could hear why she was off treatment. It was because there had been xenophobic blocks basically at her clinic by Operation Dudula, and once we worked that out, she could understand how she could access care elsewhere and hopefully resuppress. So we do need to look at translation services and improved access to multilingual patient education materials for those who may not be able to access a translation service. With that, we need to think about pictorial options so that people with low literacy can still understand. And then lastly, we just need to be engaging on a multi-sectoral level with other stakeholders to try and make sure that these women are getting what they need in terms of social safety nets, because so much of their viral non-suppression and vertical transmission risk is not coming from just simply swallowing the pills. It's coming from all the other challenges that they experience as migrants in terms of finances, food security, housing, and so on. So thanks very much for your attention, and I look forward to a lively discussion.
So maybe that was a test clap, né? A real clap is still coming. Thank you. Thank you very much. Great presentation from Dr. Natasha. And I think just in summary for things we need to highlight from the presentation, I think the issue around language is coming up more so that clinicians are then able to take a full history. And then also just to update that the patient she was talking about did come back early this week, and she was really excited about that. I also want us to discuss the issues around the proposal for a postnatal maternity case record that can be used in country and outside, meaning all the different countries will have access to it because it will be a patient-held document. Also, the issue around PrEP in pregnancy maybe what are the strategies or skills that the other countries are using so that we could increase the uptake of PrEP. Great, let's move to the second presentation because of time. So we have Ms. Frida Mahlangu, who will be presenting on viral load monitoring. So Ms. Frida is a senior program manager at VETS RHI, supporting Tshwane district in Gauteng. She holds a master's degree in public health with extensive experience in PMTCT / VTP, maternal, child, and adolescent health programs. Hand over to Ms. Frida if we can pull her presentation. Thanks. On slideshow, thanks.
Good morning, ladies and gentlemen. Thank you, Thabisa. I am Frida Mahlangu from VETS RHI, supporting the district of Tshwane in Gauteng, South Africa. Next slide, please. I will be just taking you through the efforts that we've put in place, the strategies we've put in place to reduce maternal viral load. Next slide, please. Before I start my presentation, I just want to remind colleagues about the fact that globally, we are still seeing children being infected, and we don't want that. And in South Africa, we are seeing children being infected. We need to do away with new pediatric infections. And the bad part of it is that we are having children dying of HIV-related diseases. Colleagues, Dr. Natasha spoke about bringing back humanity, and I want to add on that to say, when these children die, they don't come back. We cannot reverse death. We cannot correct death. So we can only make more efforts to ensure that we prevent these deaths. So when we look at our VTP program, previously known as PMTCT, few things should be done. The first thing being, we need to ensure that all women who are pregnant or breastfeeding or at labor and delivery who are HIV negative, we prevent transmission of disease. They should remain HIV negative. And we want to make sure that the ones that are HIV positive, living with the disease, we find them as early as possible and we link them to care, and we make sure that at least by delivery, they have been virally suppressed. And with that, we will be able to ensure that our children are not infected. However, colleagues, for us to know that our women are virally suppressed, we need to have specimen that is resulted. Now, in South Africa, what we have seen is that as much as we have put effort into making sure that mummies suppresses, but we were sitting with high specimen rejections. And when you are sitting with high specimen rejection, you will not know these mothers that are actually unsuppressed, and you won't be able to act on time. So we needed to correct that so that we can ensure that all these mummies that are not suppressed, we get them to suppress and prevent postnatal seroconversion, because we had quite a number of infants that were seroconverting postnatally. Next slide, please. Now, ladies and gentlemen, when the guidelines were updated, there was an introduction of electronic gatekeeping, otherwise known as EGK codes. So these codes are used to alert the laboratory that, guys, the specimen that you're dealing with is from a woman within the VTP program. Now, the function of these codes is to prevent sample rejection so that the lab people will not reject the sample, to ensure that we allow individual patient to be traced using the results for action records from NHLS, and to monitor viral load suppression at program level. Now, how this works is that we've got what we call C#PMTCT. Colleagues, not C#VTP, but C#PMTCT. Now, this is used at pregnancy as well as postnatal period. And then we've got the second code being C#delivery. This is what is used at delivery. Now, when you are sitting with a woman that has only one C#PMTCT recorded under her name, you know that you are still sitting with a woman at breastfeeding period. When you're sitting with a woman with #PMTCT as well as #delivery, you know that, mommy has delivered. And when you're sitting with a woman with #PMTCT, #delivery, as well as #PMTCT, the second one, now you know that this woman is breastfeeding. This is how the laboratory is able to give us data that says your viral loads, you need to start looking at pregnancy stage, or you need to start looking at delivery, or you need to start looking at breastfeeding periods. Next slide, please. Colleagues, when we started with EGK code implementation, the message that we used to receive even from national was that the effort was not even a drop in an ocean. We were not doing well as a country, as a province, as well as a district. Now, what we have done as Tshwane, we decided that, you know what, we don't want to be labeled as bad people. We wanted to improve. So what we have done was that with the leadership of the Tshwane district, and I want to emphasize that us as partners, we were led by the district in this. The district selected technical working group teams. Now, after this selection, they've also allocated what we called champions at facility level. Now, these champions, their duty was to ensure that the specimen collection tools that the nurses and the doctors were using indeed had the EGK code. They needed to provide proof of that. Now, when we collected proof, we found that indeed the clinicians were not using EGK codes, and some of them were using incorrect codes. They would write, instead of #delivery, they would write #maternity. Now, this led to more rejections. So what we have done as a TWG was to ensure that now we take training to facilities. We had road shows where we went to facilities with job aids to show them how this EGK code should be done, how they should be writing the code. Addition to that, to cut out the writing, because writing takes time, we procured stamps for them just to put on a stamp to say #delivery, to cut out writing time. After we have done that, we realized that after collecting more proof, we still were sitting with low utilization of codes. Now, we had proof that clinicians were doing the right thing. We now, as a TWG, went to the laboratory. When we got to laboratory, we found that the laboratory teams were actually not trained on the VTP guidelines. They were not aware of these things that we were doing. They continued to reject our samples. Now, working with the laboratory, we trained the laboratory teams, and then we ensured that there was quarterly supervisory support jointly by ourselves and the laboratory teams for the lab people as well as the clinicians. And with that, colleagues, I am sitting here today to tell you that we improved as a district from 45% to 74%. Now, that was a good work. When we look at other districts as well as the country itself, we are still not doing well. However, Tshwane stood up and did better. Next slide, please. Now, in order now to get mummies to suppress, we needed to use EGK codes to find out the mummies that needed to suppress. Now, for us to get mummies to suppress, we used what we called postnatal clubs. Dr. Natasha spoke about postnatal clubs just now to say in her districts, the mummies that were in postnatal clubs, all their babies, only one was reportedly seroconverted, which is a good thing. Now, we also implemented postnatal clubs, and how this was done was to introduce we marketed the service at antenatal period. This is where mummies were prepared that we've got this service, we will be clubbing you together with other mummies of the same age of your child. So the babies should be of the same age so that you can walk the walk together. If you are mummies of 6 weeks old, you will walk together. Mummies of 10 weeks old, you will walk together up until where you get discharged from postnatal clubs. Now, with this, how we implemented this, there's 4 important components. The first one being, we are using postnatal clubs following the adult ART modality. This is where now we are saying the mummies will be put together in one club. They will be seen. They will be provided with adherence counseling. They will be provided with opportunities of peer support. This is where they discuss. They talk about the importance of staying on treatment. They talk about the issues, the bottlenecks, the barriers, and they discuss how they themselves navigated through these barriers in each other's company. And addition to that, we ensured that they only not talk about HIV, they talk about other things that are problematic, your mental health, your GBV. Now, the second component was integration of mommy and baby pair. This is where now we were saying in the very same club setting, we're not going to be seeing baby only and turning mommy to another queue. Mommy will receive her service in this very same club. Her treatment will be pre-packed. When she comes, she will receive all the HIV and non-HIV services in the same club. Meaning, when we're sitting with a club of 6 weeks olds, we know that we will make sure that the treatment is available for the mummies. We will make sure that there's enough immunizations for the babies. All the services for mommy and baby will be provided at club setting. Consent would have been obtained when mummies join the club. Now, the third one is integration of HIV and non-HIV services. Now, for the mummies, we were not only looking at HIV services. For the mummies who needed non-HIV diabetes, they were managed in that club setting. Same applies to the babies. And we also looked at early childhood development. This is where now the milestones were discussed. For this mommy whose baby is crawling, they'll be celebrating each other to say, mine has started. Don't worry, yours will start. You know, that sisterhood, they enjoyed that to the point where they even had WhatsApp groups where when one mom couldn't come to the facility, they would send the other mom that is in this club to say, you can tag along with my child as please, so that my child could receive the service. Next slide, please. Now, with implementation of postnatal club, I tried to pull together data for between June 2023 to June 2024, and we have enrolled about 374 moms in the clubs. And of these, yes, we did lose some because mummies would at some stage go back to work. We did lose some. So we said with about 296 mummies active in the clubs. However, with the mummies that were in the clubs, it was easy for us to continue with our viral load monitoring. And colleagues, when we looked at their infants, only one, same as in the city of Johannesburg, only one infant seroconverted. And all the mothers, we found ourselves with the viral load suppression using the threshold of 50 copies. We were sitting with 98% suppression. It was an easy win for us because these mothers were encouraging each other to suppress, to do well for their children. They were breastfeeding. We had breastfeeding messages, although there were other mothers who stopped breastfeeding along the way, but it was easy for them to have infant feeding discussions, to have breastfeeding discussions, and to support each other along those. Next slide, please. Some of the key lessons that we have come with out of this is that we could not do anything, and we will never do anything without the Department of Health. Their leadership was key for us to succeed. And we found that integrating mother-infant pair, it works wonders when we want to ensure that mothers are suppressed and they don't infect their children. Integrating mother-infant pair works wonders. And we found that pairing mothers with other mothers for peer support, that was the best thing that we could ever do, because we were able to listen to their challenges and their needs, and we could correct their needs so that they are sitting with corrected information. I will end here and thank you.
Also, I'm the only one. Snap our fingers if we're ready for elimination. Great. It means I'm in the right room with the right people. Okay, great. Thank you, Frida. I think summary or pickup messages from your presentation would be, you know, we always talk about finding children. Probably we need to find definitions of how and where we're finding these children so that we can better focus our interventions. And then also she mentioned a 98% suppression rate. Ne? That was great for the cohort that was in the postnatal clubs. Also services for a pair in one room. How great is that a mother doesn't need to go and between another two services in one room for the pair. And I'm saying pair intentionally because we also have fathers who bring children. We also have caregivers that bring children. So great. Thank you very much, Frida. Let's move along to the third and last presentation for this session. And that presentation will be coming from Ms. Peggy Kuchocha from Zandiri in Zimbabwe. Ms. Kuchocha is a qualified and experienced medical professional with vast experience in sexual reproductive health programs and HIV management. So she's working at the Zandiri program, which is an organization which connects children and young people living with HIV to be able to survive and thrive. So over to you, ma'am. Believe you'll be using your laptop.
Thank you so much for introducing me, and good morning, everyone. Okay, my name is Peggy Kuchocha. I am from Zandiri, Zimbabwe, and I am going to walk you through our experiences in implementing the Zandiri Young Mentor Mother and Young Mentor Dad peer-led program. Next slide, please. Thank you. So before I start, I thought it is necessary for me just to magnify the challenges that we are having, or the challenges that are being faced by our young mothers. So HIV disproportionately affects adolescent girls and young women living with HIV. And these are in sub-Saharan Africa. And this is according to the UNAIDS Global AIDS Update for adolescent girls and young women. And then adolescent girls and young women accounted for 77% of all new HIV infections in 2023. And again, they live in sub-Saharan Africa. So we know that adolescent girls living with HIV, they experience multiple poorer HIV-related health outcomes compared to their older women. And these challenges, they include the following. They have a poor adherence to antiretroviral therapy. Their retention in care is hindered or altered. And they also have challenges in clinic attendance, and their viral load suppression is also compromised. And this data is also according to the Journal for the International AIDS Society. And as you can see, it's overwhelming data that we really need to act on. Adolescent girls and young women living with HIV, they experience higher rates of perinatal HIV transmission. And the prevalence of any common mental disorder was found to be highest among adolescent mothers who are living with HIV. And this was found to be 23%. And this is according to the UNICEF SRH pregnancy motherhood policy. So from the prime sessions that were done yesterday, the opening sessions, and also from the sessions, so from the prime sessions that were done yesterday in the morning, and also the prime session that was done this morning, the presenters, they gave overwhelming data on adolescent girls and young women. And I'm sure this data is quite overwhelming, and we know our adolescent girls and young women, they need a lot of care and a lot of action, which has to be done as of now. So there is an urgent need for targeted health prevention and promoting services in terms of health programming to improve the health of our young mothers who are living with HIV. Next slide. Next slide, please. Okay, so as Shandiri, we support the Ministry of Health and Childcare in triple elimination of mother-to-child transmission of HIV, syphilis, and hepatitis B. And I'm sure we all listened to the presentation that came earlier in the morning, which was emphasizing the need to incorporate hepatitis B under triple elimination. And then we are also working across the 4 pillars of the Global Alliance to end pediatric AIDS by 2030. Okay, so who are we at Sandiri? We are a local non-profit organization which has developed the Young Mentor Mother Program and also the Young Mentor Death Program interventions in partnership with the Ministry of Health and Childcare. So our Young Mentor Death Program is still within its infancy and is only being implemented in 1 district in Zimbabwe. The evidence-based peer-led interventions are aimed to optimize HIV testing, treatment, counseling, psychosocial support, and service access to young mothers who are living with HIV, their infants, and not forgetting their partners. The young mentor mothers and the young mentor dads, they are trained and mentored as peer providers. They are living with HIV between the ages of 18 to 24 years, and these are at the forefront of service delivery to their peers, and they get support from the Ministry of Health and Childcare, and they also get support from Shandiri staff. Next slide. So I'm going to talk about our impact. I think we skipped a slide. No, we skipped the slide. Please go back, we skipped the slide. Okay, so maybe before I talk about our impact, I think I want to talk about what we do under Shandiri. And we have peer-led services which are being done by our young mentor mothers and our young mentor dads, and they connect with their peers during home visits. And these home visits are done twice every month. They also connect with their peers during support group meetings, which are done once every month. And they connect through digital health, whereby they call their clients every week. And they also send SMSs or text messages almost on a daily basis, depending on the needs of the client. And as Shandiri, we support families of our young mothers. Why? Because we know that the families, they need a supportive environment for them to be able to survive and thrive. And we also support our healthcare workers. And this is done through mentorship programs so that they can be able to give comprehensive, holistic services to the young mothers. So when to pillar number 2, we are talking about closing the treatment gap for pregnant and breastfeeding women living with HIV and optimizing continuity of treatment towards the goal of elimination of vertical transmission. And how are we achieving this? This is being done through case management systems, whereby we are saying young mentor mothers, they support their peers for early antenatal care, allowing sufficient time for viral load monitoring is recommended, and then support treatment adherence to achieve and sustain viral load suppression. So the issues of booking early are of vital importance, such that the young mother is well monitored. Then support newly diagnosed adolescent young women in peer counseling, information sharing, and lived experiences to commence art and continue treatment to achieve and sustain viral load suppression. So the emphasis here, which I need to stress, is that we just don't want the young mothers to be on art, but we want the young mothers to be maintained on art throughout their pregnancy and also their breastfeeding period. Then in terms of information sharing, we would also want them to have informed decisions on disclosure to partners for treatment support, and this is done within the family. Then participation in advocacy and awareness initiatives to reduce social and cultural barriers that hinder optimal uptake for treatment and continuity. For example, we talk about issues to do with stigma and discrimination, and we also talk about issues to do with gender-based violence. So lastly, on this slide, I'm just going to talk about the referral services that are needed, and these they should be followed up, and the outcomes are supposed to be monitored. Then I'm now going to move on to the impact slide. If you can go a little bit behind. Yeah. Thank you. So I'm now going to discuss our impact. Okay, so this is our 2023 data. We are in 18 districts in Zimbabwe, and we are operating in 198 facilities or sites. We do have 156 young mentor mothers. And these young mentor mothers are supporting 1,383 adolescent young mothers who are living with HIV. And these are the ones who were raised. And the 156 young mentor mothers, they made 49,098 contacts, and these were done through home visits, facility contacts, support group meetings, and through the digital platform. And this translates to about 35 contacts per young mother per annum. Then our viral load suppression rate is 98% from the cohort of the mothers that we are supporting. Then in terms of EID, 99% of the babies were tested for EID, and 99% of those infants they tested negative at cessation of breastfeeding. Then we don't leave partners behind, because partners are support systems for our young mothers. 11% of the partners were tested, and they were tested positive, and all of them were initiated on art. Then 58% of the HIV negative partners, they were initiated on PrEP. Next slide, please. Okay, so these are our lessons learned. So adolescent girls living with HIV, regardless of the mode of transmission, they confront several clinical and psychosocial challenges which affect their health and well-being in that of their infants. Then integration of young mentor mothers within the National EMTCT program has closed the gaps in the PMTCT cascade and improved outcomes for adolescent girls and young women and their infants. Then PLH, community and facility-based support services, they ensure a differentiated response for adolescent girls and young women's needs and experiences. And young mentor mothers are supporting their peers to make safe, informed decisions on disclosure to partners in subsequent uptake of HIV testing and prevention. So in terms of disclosure, we really now need to emphasize the importance of disclosure to partners, because if partners are not disclosed to, it hinders treatment in terms of adherence and in terms of infant feeding. And then lastly, integration of gender-based violence intervention within the HIV and young mentor mother services promotes the well-being and safety of our young mothers and also their infants, art adherence, retention, and also disclosure. And one of the major lessons that we've learned is that the Young Mentor Mother program is effective and the mentors are acceptable cadre in the provision of PMTC services for adolescent girls and young women. So I'm sure you can see a picture down there, which is presenting a young mentor mother who's doing a home visit. She's supporting the spouse, she's supporting the mother, and she's supporting the family. I think with that, I thank you. Okay.
Thank you, ma'am. Sorry for the slide, the issues, ne? Great presentation around peer-led programs. And I think in summary for your presentation would be, we need to develop more peer-led services and also utilize the already existing ones. I think one key thing you've highlighted also is the partnership with the ministry. I think also Frida's mentioned the issues around working together with the government entities, because that is very key for sustainability. And then also you've mentioned partners not being left behind. And I think in this instance, you're talking to male partners, and also the integration of young women mentors into the program as an overall program itself. So thank you very much to my presenters and my speakers. A round of applause for them. So now we're gonna quickly move to exciting times where everyone gets to speak. Everyone gets to be a speaker. I'll invite my co-facilitator just to look at the online questions, but in the meantime, can I invite my speakers to come and sit here for a Q&A? You will also notice we've got Ms. Lindiwe Letswalo, who is a technical advisor for VTP in Sedibeng district in Gauteng. So we're going to, just to check in, do you have any online questions? Okay. I think let's start there. You can help me.
Okay.
Okay, so while we wait for that confirmation, let's check in the room, show of hands. Those would like to ask questions.
Okay, thank you.
Okay, wait, ma'am, I just wanna confirm. I know you are number one. 1, 2, 3, 4, 5, 6, 7, 8. Yeah. So in that order, please, we'll take a second round if we have to. Thank you.
Okay, thank you. My name is Teoka Ibadza from Zimbabwe. My question is directed to Dr. Natasha. She mentioned issues of having transfers for pregnant women, taking transfers when they are going maybe back to wherever they are coming from across the borders or from within the country. Is it always mandatory to have a transfer from a facility, or what are we doing about the self-transfer issues? Are they not allowed?
Okay, good afternoon. I'm Farero Mudau from South Africa. Mine is not a question, but rather a comment. So the speakers also touch on the universal or standard of the ANC booklet, which I think is a very great initiative, which we should really take upon. And also maybe in addition, we can also add the Road to Health booklet on that, because then we have to treat the mother and the baby as a pair. And especially if this dream can be realized, we can even start on our SADC region because we have got a lot of movements between the region or the countries. Definitely, this will improve the quality of care, the viral load suppression, and also maybe the ANC first booking in South Africa, specifically looking to the fact that will be also, or it also impact on the path to the triple elimination, whereby we're not doing so well with the ANC first visits. And also maybe the last one on the postnatal club is that as much as it has focused on HIV, I'm glad you brought the issues of integration on those support group. Also, maybe it should also include the issues of immunization, the nutrition screening, as well as the general danger signs, as this will improve the child mortality rate in our country. Thank you.
Good afternoon. I'm Henal from Mozambique. I'm working at Inhambane province. First of all, I would like to congratulate the facilitators for their representation. And my question is for Frida Mahalungu about the postnatal club. It's a great initiative. I have few questions. The first of all, how often do you hold these clubs? Are they monthly, weekly, or quarterly? And who moderate these clubs? The second question, at the clinical consultation for each mother are held on the same date of the club or another day? And that's all. Thank you.
Hello, everyone. Good job. My name is Emiliana from Tanzania. I'm speaking Swahili, then I translate. Swali langu ni kwamba nyinyi kama mashirika mnasaidiaje wale watoto ambao wako vijijini, ambao wana uhitaji mkubwa wa kupatiwa huduma za afya, hususani wale ambao wapo sasa hivi katika janga la utapiamlo. Unajua ili mtoto awe na afya njema na nzuri lazima apate lishe bora. Kwa hiyo mimi swali langu linakuja, kama nyie mashirika ambao mko hapa, mnasaidiaje wale watoto ambao wanapitia hali ngumu, ambao wako vijijini, na pia wale watoto wana uhitaji wa zile dawa zao ambazo zinaweza kuwasaidia kurudi katika hali ya kawaida, na dawa pia ni ngumu sana kuzipata kutokana na hali ngumu ya maisha. Je, mnasaidiaje, au mko katika kampeni gani ya kuweza kuwasaidia watoto wanaoishi vijijini wenye hali ngumu?
Okay, thank you. How are we supporting infants or babies who are living with HIV, but they have malnutrition, and yet they are taking a lot of medications, and they are living under very difficult conditions in the villages? How are we reaching them? How are we supporting them?
Colleagues, I'm Unati, I'm from Eastern Cape, South Africa. Something that I would like about the young mothers, but the focus, it was young mothers living with HIV. But I don't think we can eliminate HIV. It will only focus on young mothers living in HIV, because also young mothers without HIV, they are having the same problems with the one that HIV, because they drop school and having dating their sugar daddies and end up having HIV. So there are also the risk that we have. So in your part of the young mothers and daddies, we include both HIV or non-reactive, so that we can manage them holistically. And also in the part of the management, integration of the services, the immunization. Most of the time we forgot about the immunization and the family planning in that phase. We only focus on the HIV and PrEP, we forgot about the family planning. I think we need to strengthen the long-term treatment, long-term family planning in those situations. Thank you very much.
Morning, everyone. My name is Victoria Manzi from Zambia. I have two questions. Thank you very much to the presenters. My two questions are going to the last presenter from Zimbabwe. Very good lessons there. As a country, we are looking forward to learning all the initiatives that are there, especially as we go towards 2030. So I would like to find out, for the model that you are implementing, what is the age range for the young mentor mothers, and what's the criteria for having someone as a young mentor mother? Are they all living with HIV, or you also have those that are HIV negative? I think a follow-up question to the previous speaker. Then my second question is, I noted that all the negative partners accepted PrEP. What strategies did you use to ensure that the male partners accepted PrEP? One of the challenges or one of the struggles we have to achieve EMTCT is lack of male involvement and multiple sexual partners. So how did you handle the issue of young mothers who tested positive or are living with HIV and have multiple sexual partners? And how did you bring the male partners on board? Thank you.
Good morning. My name is Véronique from Cameroon. Please, I want to speak in French. OK. Alors, je tiens d'abord à féliciter toutes les présentatrices et intervenantes pour cette différente présentation. Alors, j'aimerais adresser une question à au docteur Natacha, qui nous a parlé.
So because we don't have enough, just want to check if everyone has a translator. Okay, great.
Alors, j'aimerais adresser une question au docteur Natacha et pour nous tous, parce que dans notre communauté, je travaille dans le sud Cameroun, nous avons des populations qu'on ne dirait pas qui migrent, des populations qui vont dans en brousse pour faire un certain nombre de temps qui ne sont pas nécessairement déterminés. Ces populations sont des populations qu'on appelle les populations autochtones, les populations Baka, les populations pygmées. Donc, ils vont de temps en temps en brousse pour peut-être avoir des activités de chasse et dont on ne connaît pas le moment auquel ils doivent rentrer dans leur communauté. Alors, elle nous a présenté tous les modèles différenciés qu'on peut appliquer pour des populations qui migrent, que ce soit des migrations internes, parce que lorsque on a une migration interne, on sait que tu passes d'un district à un autre. Pour ces populations-là qui vont en brousse, il n'y a pas de district là-bas, il n'y a pas de formation sanitaire en brousse. Comment on peut les gérer à notre niveau? Parce qu'on ne connaît pas exactement quand elles doivent rentrer. Alors, j'aimerais aussi poser une question à notre sœur qui nous a parlé des modèles mentors et des pères qui aident dans la sensibilisation, dans la prise en charge des femmes. Est-ce que, puisque c'est expérimenté actuellement dans un district, est-ce qu'il y a une certaine organisation au niveau de leur pays pour étendre cette façon de faire dans les autres districts? Et est-ce qu'on a réfléchi, parce qu'ils ont des aides, des subventions, est-ce qu'on a réfléchi après ces subventions, comment cette activité va être continuelle dans la longueur? Merci.
Hello, good afternoon. I'm Bridget Mwape from Zambia. First of all, I would love to commend Dr. Natasha for the beautiful presentation she had. And on the maternal record, which she presented, I like the fact that it had a part where it was showing viral loads, which were done on the mothers, which is very good. Besides the usual testing, retesting dates, but there were viral loads, which I think is very good for our mothers for monitoring. My question goes to Frida. You mentioned about CH-Tech, PMTCT delivery and breastfeeding mode of monitoring. So I wanted to find out if there is a different monitoring indicator for the for those mentioned, which is PMTCT delivery and breastfeeding, because initially you mentioned that there were some errors and samples were being rejected. So are there different indicators to look at those three? And then my second question is, was there pre-training done to the staff at ground level before these issues of codes were implemented? Thank you.
Thank you very much. So I'm just checking, do we have, yeah, okay. I'm coming to you, I'm coming to you. I just want to check if we do have a French speaker to help us interpret you. Okay, great. Because I want her to have her response in her own language so she can understand. So I was meant to take a second round. I just want to check who else still needs their question asked besides my team here. Because I also don't want to overwhelm our speakers for them to respond. Okay, so I'll take the last one, and then we see if we still have more. You can't hear? Okay, so let's just take the last one. I'll come to you.
Thank you. My name is Graça from Angola. I will speak in Portuguese, please. Translation.
My name is.
Ok, a minha questão, desde já agradeço a apresentação dos preletores. A minha questão é para Zimbábue. A minha questão é para Zimbábue, sobre a apresentação do pacote Zivendere. Sabemos que ele é um pacote completo, tem a mentoria jovens, mães, jovens e pais. E durante a apresentação, tivemos a oportunidade de ver o impacto dos resultados, lições aprendidas, mas não consegui ver os desafios. Já que ele é um pacote completo, foi apresentado o impacto de resultados em crianças, que eu parabenizo desde já, com maior percentagem de crianças diagnosticadas negativas e maior percentagem da supressão viral, mas não vi a estratégia com relação aos pais. Se houve estratégias implementadas pelas mães e jovens, quais são essas estratégias que podem ser aproveitadas para alcançarmos também pais mentores? Essa é a minha questão. Obrigada.
Thank you very much for the questions. Now let's try and respond to some of those questions. I think the cross-cutting ones were around the inclusion of road health cards, right? And also looking at a SADC region implementation of both MCR and Road to Health Card. And then also the other one was reaching people in the rural areas. I'd like for my speakers to talk to that. How are you finding people that are in hard to reach places? And then I think the comments were for the long-term family planning. And I just want to clarify, this pillar is pillar 2 of the Global Alliance, which talks to your HIV positive women or women living with HIV. We also have a pillar 3 that looks at women who are HIV negative and kind of highlights the preventative modalities that are there. So just to understand the difference between the 2 pillars. So I'll hand over. Let me start with you, Frida.
Thank you. Okay, thank you. Okay, thank you so much. I'll start with the first question that spoke to the postnatal clubs and how we're doing that, and are we separating the mother and child and infant healthcare services. Now, with postnatal clubs, how we do this club, we are aligning the clubs with the EPI visits. This is the immunization visits. So for example, at 6 weeks immunization visit, we will be seeing mommy and infant. We will be providing services for mommy, and some of those services includes the ARV care, as well as other HIV care that will be significant for that period. We will also be providing other healthcare, such as your mental health screening, such as gender-based violence screening, all those healthcare. And if we're sitting with mothers who've got other illnesses like your chronic illnesses, your diabetes, your hypertension, they are provided in that same setting. So we are providing a comprehensive healthcare for the mother. For the baby, we are also providing a comprehensive healthcare. Remember, this is an infant that is exposed but not yet infected. So we will be doing our routine HIV testing on this infant. We will be providing, if this infant is still on prophylaxis, we will be continuing with our prophylaxis. We will be continuing with our immunization for that period. We will be doing our nutrition assessment and counseling services for this mother-infant pair. We will be looking at things like your breastfeeding, supporting the mother, making sure that the mother is doing it right. If the mother is not breastfeeding, doing other methods, we are making sure that these methods are safe for the infant. So it's a comprehensive package that is aligned with the EPI visits. The idea is not to deviate from the existing programs, because EPI program has been there. So we didn't want to include something on top of something and to make the mother come multiple times. Mothers are going to work, they don't want to come multiple times to facilities. So we are sort of trying to make sure that in that one visit, we do everything. And we don't just close doors on other family members. The beautiful thing about postnatal care clubs is that if mommy is not available, daddy can still come and daddy will still receive the services. Granny can still come and granny will still receive the services. And in terms of how do we try to reach those children and infants in hard to reach places, we work as I think Tabisa will also speak to this, and I do have my other teams from South Africa who will speak to this. However, we do have what we call ward-based outreach teams that gets into the households, and they are teams that comes from communities, and they work in these communities, so they know where problems are. They know when the definition of hard to reach place, they know it more than us because they come from those areas and they don't work alone. We've got other partners, the OVC, Orphans and Vulnerable Children partners that are working with them to get into these hard to reach places. And when they get there, they don't just provide they don't just address food insecurities by providing food. They also assist the families. They touch base with the Department of Social Development. They assist families with things like helping the mothers on how to register for employment, easy things like writing a CV, you know, just to make sure that this family can benefit not only from the grocery that will be given on that day, but even in future. They do things like gardening. They give them seedlings to plant gardens at household so that these gardens can feed the family, or they can use it to sell and buy some stuff. In terms of the question of EGK codes, the first part I didn't understand, and I think Tabisa, you can help there, or Kulan, you can help. But the question that spoke to, did we provide training? So when we started, we provided EGK code training within the VTP training. Now, we realized later that as much as we have provided this training within the VTP training, not everybody came for VTP training. Hence, we needed to now go back to facilities to touch base with everybody at facility level, because it is easy to think that Frida has gone to training and Frida will come back and teach everybody else. But it's not always the same thing, because when Frida goes back, she finds that there's a queue waiting for her. There's no time to transfer skills to other people. Hence, we needed to take this training back to the facilities ourselves, and not just training as well as job. I think I'll end there and allow my teams to.
Okay, thank you so much for the questions. So I am going to try to respond to the questions. So in terms of supporting babies with HIV and nutritional challenges, yes, I think we also heard from the presentation that was done earlier in the morning that babies who are below the age of 5 years living with HIV, they are classified as babies with Okay, thank you so much. Is this okay now? Okay. Okay, so I want to respond to the first question, which was talking about supporting babies with HIV and nutritional problems. So from the presentation that was done even earlier in the morning, it was talking about classification of our babies who are living with HIV. And we know that when someone is living with HIV, a baby is living with HIV, and they do have nutritional problems, they need care. And we really need to treat or to look at the HIV component first and make sure that this baby is not in advanced HIV disease. And we make sure that this baby, the CD4 of the baby is tested, the viral load of the baby is tested, the weight is done, the MUAC is done, and we manage this baby. And usually when this baby is well managed, if the baby is living with HIV and the baby receives adequate support from a caregiver, the nutritional status of the baby usually starts improving. But at the same time, there's no harm in addressing the HIV status or situation of the baby, at the same time trying to address the nutritional challenges that the baby is facing. So in terms of nutritional challenges, there are a lot of issues to be considered. We need to look at the diet of the baby, or the food availability, what exactly is happening within the household, and how can we refer maybe the baby to access additional services. Then there was also a question on PrEP, and it was on how we managed to link our male partners on PrEP. So we work in collaboration with the healthcare workers, and these healthcare workers, they give information on PrEP at each and every contact with the male clients. And we have also worked on addressing a lot of myths and misconceptions in terms of PrEP. And the other thing that we have found important and working is that we have offered, or the young mentor mothers, they offer escort services to the healthcare facility when a male client requires PrEP. Males, they don't want to go to the facilities. Males, they don't want to wait. Males, they don't want to be in a queue. So when the young mother knows that the male partner of a young mother is coming, the young mentor mother knows the male partner of a young mother is coming, she offers to escort her so that they can navigate the complexity of the healthcare system so that they can get access to treatment as fast and as early as possible. Then moving on, there was also a question on the criteria for the young mentor mothers. So our young mentor mothers are supposed to be between the ages of 18 to 24. They should have undergone labor and delivery. And this is key because we are saying they need to walk the talk. They need to lead from the front. When they are mentoring a young mother who is either pregnant or lactating, they should tell her their story. What have they done and what are they doing? Maybe to achieve viral suppression or maybe to make sure that their baby tests negative at cessation of breastfeeding. So this young mentor mother is supposed to be either pregnant or lactating, or she should be having a child. And then they're also supposed to be committed to being a young mother, and they are supposed not to be in school so that we don't disturb their education. Then there was also a question on strategies in terms of the young mentor mothers, what we've done for them to be this effective. So there are some tools that we use under Shandiri, and we have the caseload planner, which is used by our young mentor mothers to plan their work. So at the beginning of each and every month, a young mother sits down with the healthcare provider, looks at the number of clients that they are supporting and what services do they need during the month. And they follow this caseload planner throughout the month. Does this client need a home visit? Does he need, what are the challenges? Is this client having a viral load? Do they want adherence counseling? Because they can even offer this adherence counseling during their home visits. And the supervision is usually done at the healthcare center, and this is done by the healthcare workers, and also Shandiri also chips in supervising. In terms of training, they are trained by Shandiri, but they are supervised and accredited by the Ministry of Health. So this is what we are doing in terms of them managing to achieve the impact that we've been talking about. Then there was also a question on young mothers living with HIV and them only being HIV positive. Yes, the model that we are using under Shandiri is talking about young mentor mothers who are supporting their peers who are living with HIV. And we are specifically talking about pillar number 2, whereby we are talking about prevention of vertical transmission. But in terms of immunization and family planning, this we make sure that our mothers, they access family planning methods, and our current OIAT booklet that we are using that has been improved by the Ministry of Health. I'm happy to say it has got a component on family planning such that we don't miss that common component, and we make sure that our mother is on a reliable method of family planning. I think, lastly, there was a question on the Young Mentor Date program. Yes, we are working on trying to expand the program because at the moment it's being implemented only in one district. And let me quickly say that it's a great program, and it follows the same format like the Young Mentor Mother program. And it also addresses issues to do with deaths and also adolescent boys who are also sexually active. So in future, I'm sure we can be able to expand this program so that next time when we do such a conference, we'll be able to shine about the program. Thank you and over.
Good afternoon, colleagues. I'm just going to be brief because I believe okay. Good afternoon once again. I'm just going to be brief because I believe my colleagues have touched on some of the questions that were posed. So the question that was posed to Dr. Natasha's presentation was based on the ART transfer letter. So to answer that, a transfer letter, it's just a document that we felt that is necessary for continuity of care. For instance, if we have a patient who's migrating from a region to another region, we would like to know the clinical evaluations that were done, the viral loads that were done, so that we continue from what has been done previously. But it is not a mandatory document. As you've seen, it was just highlighted as a gap that we are seeing in our country, that some of the professional nurses are using it like as a barrier for some of our patients to access healthcare. But it is something that we are working on as technical advisors to continuously emphasize the policies and acts that say that every patient has a right to access healthcare, especially pregnant and breastfeeding women. So I'd like to also touch on the comment that was made on the maternity case record that can be used in the postnatal period. It's with the same aspects that when we have like the ANC maternity case record, what I say to my patients is that this is your passport, ne? So when they move around from one facility to the other, they can actually take this maternity case record to the other facility so that, like I've mentioned before, services can just continue. So the postnatal one would also be great to have. So if it's something that we are agreeing on, it's something that we can look into so that we implement it so that our patients don't get turned away from facilities, so that they all receive equal quality care.
Great, thank you very much. So we have about 15 minutes left. Okay, so there's an online question coming up. But I wanted us to respond to her question just in one line, because I think she was mentioning the issues around the VTP program itself. What can we do differently as strategies for vertical transmission? So we have an online question from Mary. What is the purpose for the foreign patient rubber stamp at the hospital? Are there immigration officers within the health facilities, within the borders, and what would be their role as per health service delivery? So I'm assuming this talks to the first presentation from Dr. Natasha. Did you get that? What is the purpose for the foreign patient? You see, Dr. Natasha mentioned that there are stamps that are put up. Sure, thank you. One last one.
I actually want to respond.
Oh, okay.
There was a question asked to Frida, but she couldn't respond.
Okay, so I'll take you, we don't have enough time, ne? Okay, and you also, thanks.
It was about EGK code indicators. I'm not sure if I got the question right, but we do have indicators reporting the EGK code, although it's not linked to our DHIS for now. We are relying on NHLS, which is National Health Laboratory Services. So they are helping us every month to track that. Remember, all the samples are going to the lab. Then they try to track that when the code is written. So the challenge now based on the presentation from Frida, if the clinicians are not writing that code, you can't track it. It's like it was not done. That's why it gets rejected. But we are on the process to put these indicators on the HIS for 2025. Hopefully it will be approved. Thank you.
Good afternoon. So my question goes to our Zimbabwe speaker. So your strategy is beautiful. Do you pay them? Do you pay the peer mentors mother? Is there any form of pay? Is there any psychological support for the trauma people after they refer them to? Is there, because I know they are health workers, so how do they provide the psychological support for them? Okay.
Is it working? Okay. Thank you so much for your question. When it comes to stamps, I'm not sure if we heard Dr. Natasha speak on the presentation that this is one of the things. She said it's a horrible thing to do. So it's one thing that we are not happy seeing in our patients' files, but it is actually used for statistics purposes to see from for the patients if they're from around or out of the country. And we have a system called HPRN, which is a patient identifier system. So this system uses ID numbers for us to register the patients, for us to be able to identify. So most patients that come that are undocumented, so it will be highlighted with that horrible stamp that we saw there. Yeah. Thank you. The second question?
Okay, thank you. Okay, so thank you for the question. So our young mentor mothers, they receive stipends every month, and this is done in collaboration or in consult with the Ministry of Health. And in terms of their mental health, maybe before I talk about their mental health, let me just quickly say they enjoy supporting their peers. And especially considering that they'll be having babies who haven't seroconverted at the end of their breastfeeding period, they are so happy to share these experiences with the fellow young mothers. And then in terms of their mental health, we do have a program, a dedicated program under Shandiri, which is called Wakakosha. And Wakakosha in Shona, it means I'm worth it. So this is a program on reducing self-stigma, and it actually improves the self-worth of our young people who are living with HIV. So this, at the end of the day, improves their mental health. So we support them, and we also screen them for mental health each and every 3 months. Specifically, the services that we offer our young mothers are the same services that we offer our young mentor mothers. We call it care of the carers. So they are still our clients and they are still our Shandiri clients. So we give them equal services, just like the services that they are giving to their young mothers. Thank you.
Okay, there's another question online asking about immigration officers in the facilities. No, we don't have immigration facility officers in the healthcare facilities. So I'm not sure if it's talking to the stamp that they saw there, but I think that stamp, it's just an internal SOP that the facility has come up with for their own statistics or identification purposes. So I would just like to emphasize on something. This immigration officer question just reminded me of something that I would love us to have in our facilities. Like in the presentation, Dr. Natasha alluded to information pamphlets that speak in different languages for us to be able to address like different people from different cultures. So it would also be nice to have translators in the facilities, because sometimes the information that we get from our pregnant and breastfeeding women, it's not reliable because we cannot actually communicate with them. So what I do, luckily for me, I see myself as one of the fortunate healthcare workers because my husband is multilingual. So with the patients concerned, what I do is ask if I can assist the patient with my husband translating. So that helps me a lot. So yeah, I believe it's something that we would like to have in our facilities in future that will help us a lot, that will also help us to provide quality care to our patients. Yeah.
Yeah, it's working. Thank you very much. Love how you were so innovative there. Can we still snap our fingers? Are we good? We're fine. Thank you very much for sitting in this session. I think that was our last comment. And probably also just to highlight that yesterday we had a very engaging session and just like today. But the one thing that stood out for me yesterday was when we had a quote that was saying fathers are not escorts, but they are also parents. So I'm just bringing it out to us to say probably we need to look at this male engagement, partner involvement, fathers playing a role into the VTP program, because we understand that it takes two to tango. Ne? And then also today's presenters have highlighted the issue of government entities coordinating and kind of like monitoring what is being done within their countries so that we can manage the issue of sustainability. So those are, I think, my take-home messages, and greatly appreciate your support to this session. I'd like to thank you, my speakers. Thank you very much. We still have tomorrow. Just to highlight that the session will still be a repeat session tomorrow, but in the Lakeview Executive Boardroom, and it won't be streamed live tomorrow. There will be another session here. And then we also have a VTP. Oh, thank you very much. We also have a VTP side meeting next week with MOH delegates that are coming from different countries. We are also still excited to hear more about the strategies that she had mentioned around what do we do to prevent vertical transmission. So from me, thank you very much. I'll give over to.
Thank you very much. I have an announcement. Please visit the marketplace during the lunch until today. The marketplace is in the same place that you collect your baggage and your identification. You can find some tools, some posters. All of you are welcome there. Thank you very much.
Thank you.